For the best medical and paramedical lectures, subscribe to our channel and press the bell icon to stay connected with us.
Good morning friends. Today I will going to teach you about an interesting disease condition which is myocardial infarction. Now what is myocardial infarction? Myocardial infarction or heart attack are terms used anonymously, but the preferred term is MI. Mostly people use term is MI. And in an MI, an area of the myocardium is permanently destroyed. Now what is MI? MI is defined as when myocardium layer of the heart is permanently destroyed. It is called MI. And MI is usually caused by reduced or decreased blood flow in a coronary artery due to rupture of atherosclerosis plaque and subsequent occlusion of the artery by a thrombus. It means if there is a plaque formation or thrombus in coronary artery, it will reduce the blood flow to the heart, which will cause MI. Now, Etiopathophysiology. MI refers to the process by which myocardial tissue is destroyed in the region of heart that are deprived of an adequate blood supply because of reduced coronary artery blood flow. It means the myocardial tissues will be destroyed because of deprived oxygen supply to the or deprived blood supply to the myocardial layer, which will cause MI. Now 80% to 90% of all acute MI are secondary to thrombus formation. 80% to 90% of MI are caused by the thrombus formation. When thrombus develops, perfusion to the myocardium distal to the occlusion is halted. It means the blood flow to the heart, or means the passage of blood flow is halted for some time due to thrombus formation, resulting in necrosis. Because of thrombus formation, the blood supply to the coronary artery will be halted, so it will cause necrosis. The acute MI process takes time. Cardiac cells can withstand in ischemic condition for approximately 20 minutes before cellular death begins. Means it is not like that if we are having heart attack we will death suddenly. Cardiac cells can withstand almost about 20 minutes before cellular death begins. The earliest tissue to become ischemic is the subendocardium. Now the earliest tissue which will become ischemic means inadequate blood supply. The earliest layer which is endocardium, which will get subsequently lack of blood supply. Due to that, the earliest tissue will be endocardium. If ischemia persists, it takes approximately 4 to 6 hours of the entire thickness if the heart muscle to become necrosed. It means if ischemia persists for a longer time, it will almost take 4 to 6 hours for entire thickness of the heart muscle to become necrosed. Now areas of necrosis. You can see that white arrow is here. It is the area of necrosis. Infarction are usually described based on location if damaged. Now infarction are usually described on anterior part, inferior part, posterior part or lateral wall. Description are used to further identify the MI. The type of MI, there are mainly two type of MI. ST segment elevation myocardial infarction STEMI and non-segment elevation myocardial infarction NSTEMI. In the STEMI, it means it is more serious condition and it is caused because one of major arteries is blocked in the heart, and it is very serious condition, while NSTEMI is not a very serious condition. Now clinical manifestations of MI. Cardiovascular. First we will see what are the clinical manifestations in cardiovascular area. Now chest pain. Normally chest pain occurs suddenly, severe immobilizing chest pain that not relieved by rest. The chest pain will not be relieved by rest, position change and medications. Increased jugular venous distension because of thrombus formation. BP may be elevated because of sympathetic stimulation or decreased BP because of decreased contractility. You can understand this. Decreased pulse rate. Now ST segment and T wave changes. ECG may show tachycardia, bradycardia or dysrhythmias. Now respiratory area. What are the clinical manifestations we can see in respiratory area? Shortness of breath because of lack of blood supply. The lungs will get reduced blood supply and it will cause shortness of breath. Dyspnea, tachypnea and crackles if MI has caused pulmonary congestion. Pulmonary edema. Now GI tract. What will happen in GI tract? Nausea and vomiting. Genitourinary. Decreased urinary output may indicate cardiogenic shock. Now skin. Skin will become cool, clammy and diaphoretic. Diaphoretic means sweating, perfusion. The skin will be sweat or sweating will be seen in this type of patient, and pale appearance on skin. Now neurologic symptoms: anxiety, restlessness and lightheadedness. Psychological fear with the feeling of impending doom, or patient may deny that anything is wrong. Means patient will deny that anything is wrong. Nothing is wrong. The patient will be denied this. Now complications. Dysrhythmias. Dysrhythmias means abnormal heart rhythms, acute pulmonary edema, heart failure, cardiogenic shock, papillary muscle dysfunction, pericarditis and cardiac tamponade. Cardiogenic shock means heart suddenly can't pump enough blood to the demanded area. It is called cardiogenic shock. Now assessment and diagnostic findings. The diagnosis of MI is generally based on the presenting symptoms, the ECG and the laboratory test results. For example, serial cardiac biomark valve. Patient history. The patient history has two parts: the description of presenting symptoms and the history of previous illness. Means mainly we will see two type of history: the presenting symptoms and the past illness. Means if the patient has past illness of the cardiogenic shock or cardiovascular disease, etc. Now ECG. The ECG provides information that assists in diagnostic acute MI. ECG is main laboratory report that will show the acute MI. It will help in diagnosing acute MI. It should be obtained within 10 minutes from the patient's report or chest pain. The ECG should be taken after 10 minutes or within 10 minutes after reporting complaint of chest pain. Echocardiogram. Laboratory tests are cardiac biomarkers, creatinine kinase MB or CKMB, myoglobin, troponin T or I. Now the medical management. The goal of medical management is to minimize myocardial damage, preserve myocardial functions and prevent complications. Means we have to preserve the myocardial functions and we have to prevent the further complications. Minimizing myocardial damage is also reducing myocardial oxygen demand and increasing oxygen supply. It means we have to increase the oxygen demand and supply. We have to balance the gap of the demand and supply. Now pharmacological therapy. The patient with suspected MI should be given aspirin, morphine sulfate and beta blockers. Aspirin should be given to thinning of blood. Morphine should be given for painkillers and beta blockers you all know. Now thrombolytics. Thrombolytics are usually administered IV, although some may also be given directly into coronary artery. Thrombolytics are given to thinning of the thrombus formation in coronary artery and to reverse the supply of blood flow to the heart. The purpose of thrombolytics is to dissolve and release thrombus in coronary artery, allowing blood to flow through the coronary artery again. Means reperfusion. Minimizing the size of infraction and preserving ventricular function. Thrombolytics should be given to dissolve the thrombus in coronary artery and to regain the passage of blood flow to the coronary artery. Thrombolytics should not be used if the patient is bleeding or has a bleeding disorder, because the thrombolytics, if we give thrombolytics to the patient with bleeding or bleeding disorders, that will increase the bleeding of the patient. so we should not give that to the patient. To be effective, thrombolytics must be administered as early as possible after the onset of symptoms that indicate an acute MI. Means we should give the thrombolytics as soon as possible after we know that patient have acute MI, generally within 3 to 6 hours. Now, contraindication of thrombolytic therapy. What are the contraindications? Previous hemorrhagic stroke, known intracranial tumor, active internal bleeding, severe uncontrolled hypertension, recent head injury, current use of anticoagulants. Means these are the contraindications in which we should not give thrombolytic therapy. Because of this contraindication, and thrombolytics will increase the bleeding, and this patient will not uh, cannot bear the pain or bear the blood flow because of thrombolytic therapy. Now, analgesic. Morphine sulfate administered in IV volumes to reduce pain and anxiety. Morphine should be given to reduce pain and anxiety. The cardiovascular response to morphine is monitored carefully, particularly BP and respiratory rate. Cardiovascular response should be monitored after morphine is given. Now, angiotensin-converting enzyme inhibitor (ACE) inhibitors. Now, emergent percutaneous coronary intervention. What are the interventions should be done? The CABG and PTCA, coronary artery bypass grafting and PTCA. Now, cardiac rehabilitation. Cardiac rehabilitation is a comprehensive long-term program that involves periodic evaluation, prescribed exercise, and education and counseling about cardiac risk factors modification, in which we have to evaluate a whole process. It is a program in which we will evaluate, prescribe exercise, and education and counseling about cardiac risk factor modification. Now, indications of cardiac rehabilitation. What are the indications of cardiac rehabilitation? That are myocardial infarction, post CABG, after the CABG is done, angina pectoris. Angina pectoris means severe pain in chest, percutaneous coronary intervention, heart transplantation, coronary artery disease (CAD). These are the indication for the cardiac rehabilitation, in which we have to we have to check up the patient and evaluate the patients regularly. Areas of cardiac rehabilitation: smoking cessation, lipid management, weight control, BP control, improve exercise tolerance, symptoms control, psychological well-being, and stress management. These are the areas in which cardiac rehabilitation should be done. In cardiac rehabilitation, we will see about smoking cessation, lipid management, weight control, BP is controlled or not, improve exercise tolerance, symptoms are controlled or not. We will see all these things in cardiac rehabilitation. Now, the nursing management for a patient with acute MI. What is the nursing management for this type of patient? First, achieving a balance between myocardial oxygen supply and demand. We have to maintain the gap between oxygen supply and demand. These are achieved by oxygen administration and medication. Oxygen administration should be done and medication should be done to achieve the oxygen supply and demand. Prevention of complication, continuous monitoring of cardiac function, continuous ECG monitoring, hemodynamic monitoring, monitor and record intake and urine output. We have to monitor intake and output of the patient. Closely monitor and prevent complication associated with MI, particularly dysrhythmia and cardiogenic shock. We have to monitor particularly about dysrhythmias and cardiogenic shock. Provide emotional and psychological support. Explain and provide adequate information and knowledge about disease, cause and treatment and process. Okay. Now, risk factor modification. Daily fat intake less than 309% of total calories. Maintenance of serum cholesterol level. Maintain LDL level less than 70 mg per dl. Stop smoking and reduce daily salt intake. What should we have done to reduce the risk of MI? What we can do to reduce the risk of MI? These are the main topics: maintenance of serum cholesterol level, maintain LDL level less than 70 mg per dl, stop smoking, reduce daily salt intake, control hypertension and diabetes, increase physical activity and reduce weight. Now nursing diagnosis. Ineffective cardiac tissue perfusion related to reduced coronary blood flow from coronary thrombus and atherosclerosis plaque. Risk for imbalanced fluid, death of anxiety, deficient knowledge about post-MI and self-care. Now this was the disease MI. You can ask me anything if you have any problem. Thank you so much.
Do like, leave a comment, and share with your friends.